Okay, bye-bye.
Bye. Bonne
Bonne
journée.
journée.
Okay, good morning, good afternoon, and good evening to people that is connected. This is a special session for the Congenital Art Academy. Today, we are going to start a new appointment that we will have every 15 days with some colleagues that are visiting us for Congenital Art Academy Fellowship Curriculum. So it will be our pleasure to every 15 days found a paper that we like to share. We make some comments and we can at the same time discuss about some common case or some common problem we face in our clinical practice. We have 4 colleagues for this year in Mediterranean Congenital Art Academy program, and one is my pleasure to introduce. Is a colleague from Haiti. The name is Samantha Menager. She's a pediatrician. She's working very well. She's the one that arrived first year for the program. So I'm thanking her for the invitation and acceptance to present this first paper. And I think now she was ready like 5 hours ago, and now she's more ready to share with you the experience. Let's start again. Yes, only click and go ahead. Okay. Sit. Oh. Here's your place.
Good evening, everyone. It's a pleasure for me today to talk about a very important subject, and I give my thanks to the Congenital Art Academy for this opportunity. And today we will talk about the infant with Down syndrome and congenital heart disease. So as we know, these infants have many problems. They are more likely to develop like less human response. And facing this case, in the last week, we had children with Down syndrome, with fever, but perioperative, and they postponed the intervention. So I wonder why, if we know that those children have less or poor immune response, why not do the intervention? So this brings me to this paper, and
click on the mouse.
and the title of the paper is Infant with Down syndrome and congenital heart disease have altered perioperative immune response. And the two main authors were Lyudmila Zakharenko and Ashif El-Kusha. And the article was published in the journal Spring Nature. And the Springer Nature Journal is an open access journal with a very high impact factor for the last update. And the journal was received on May 2022, revised on December 2022, accepted on February 2022, and published on May 2022.
The people see everything.
Okay. And for the study, it was realized in the Children's Heart Center at Crumlin in Ireland, and this center is the only pediatric cardiac surgical unit in Ireland. And there is about 500 cardiac surgery in the center annually, and over 20% of children coming in the center for corrective cardiac surgery have the diagnosis of Down syndrome. And to realize the study, they add the financial support of the National Children Research Center and other open access support. The first author, Lyudmila Zakharenko, is a pediatric cardiology, and she is affiliated to the Children's Health Ireland. And also she was a fellow at the National Children Research Center at Crumlin in Ireland. She already published 3 papers with a mean of 93 reads. And the 2 other papers she published are also related to Down syndrome and congenital heart disease. As we know, the Down syndrome is the most recognizable abnormality, chromosomal abnormality in children. And those children have a very altered innate and immune response, and also they present an altered toll-like receptor signaling, and also a decrease in the endotoxin response. So this dysregulation of the pro and the anti-inflammatory stocking really release normally in setting of infection, and can lead in those children to very bad outcomes. So they are also susceptible to severe infection, and they present like an increased stay at hospital and at intensive care, and also they are more likely to develop sepsis, and they have higher incidence of postoperative chylothorax and an increased mortality. So in the literature, it says that they are more pronounced, they have a more pronounced immune response compared to children without Down syndrome. And the impact of this poor and anti-inflammatory state on the short-term outcome in children with Down syndrome in the perioperative is, as we say, can lead to very bad outcome. So for the study, the author has the aim to characterize the inflammatory response in children with Down syndrome and in children with congenital or Down syndrome and congenital heart disease, and also in children with congenital heart disease, but with a normal chromosomal complement in the perioperative period. She came with the hypothesis that the assessment of anti-inflammatory state in the perioperative period could lead to could describe the effect of Down syndrome in infants with congenital heart disease on complication, morbidities, and postoperatively, and also could have a significant impact on their monitoring and management perioperatively. For the study design, it was a prospective observational study realized on 2 years from July 2018 to July 2020. And the study was at the Children's Heart Center in CHI at Crumlin. And the study population was divided in 3 groups. And we had the first group, it was the children with Down syndrome and congenital heart disease. The second one was the children with congenital heart disease, but normal chromosome, so without Down syndrome. And the healthy control were recruited also just to make comparison. And for the study intervention, the author relies blood sampling for the patient, and the sampling was rejected if hemolyzed. So the children with the surgical cohort had 3 blood sampling on pre or post-op and before the discharge, and the control group had only 1 blood sampling, and they realized the serial serum cytokine panel by multiplex ELISA, and they were searching for the value of interleukin, TNF alpha, TNF beta, vascular endothelial growth factor, and also erythropoietin. The inclusion criteria were for the first group, the infant with a confirmed diagnosis of Down syndrome admit for surgical repair, and the heart disease, they recruit in this cohort where the complete AVSD and also children with VSD. And the second group were the infant with a normal chromosomal complement and congenital heart disease, so congenital heart disease only. And they made this group just to compare with the Down syndrome group. And for the 2 surgical cohort, the gestational age should be more than 33 weeks, and the age prior surgical intervention should be between 3 and 7 months. And also the control group were only matched by age. It was 3 to 7 months also. So she made a list of exclusion criteria. It was the infant with suspect or defined chromosomal or genetic abnormality other than Down syndrome, and the case of cyanotic or obstructive cardiac lesion, and also including serology of fellow, and the children with major comorbidity like cancer, liver and kidney disease, brain abnormality, and children who require intensive care in the neonatal period. And also one of the exclusion criteria were children less than 33 weeks, gestational weeks. For the study, the author has the ethical approval from the Ethic and Research Board of the Children Health Ireland, and the patient consent was not required for this study. And the author declared that she has no competing interest. The statistical analysis were realized by and he used the Kolmogorov-Semyonov test. For the the test was used only for the data where they have a normal distribution. And in case of the distribution where asymmetric and abnormal, they made a log transformation, and also they used the greenhouse gas correction, and a two-way analysis of variance was used to compare like the serial cytokine result in perioperative. And he consider the statistical significance at a p-value less than 0.05, and he made the analysis with using a, SPSS version 26. For the study, first she had 196 patients, but only 94 patients were recruited and divided in three groups. The first one with congenital heart disease and Down syndrome were 55 patients, and the second one non-Down syndrome and congenital heart disease 29 patients, and the control group 10 patients. For the result, this table talk about the demographic of health children compared to children having surgery with congenital heart disease and Down syndrome, and children with only congenital heart disease. And we can see for the Down syndrome and congenital heart disease group, they had less the gestational birth, the gestational birth age were less than the children with congenital or only congenital heart disease, and it was a significant result with a p-value less than 0.05. And also for the Down syndrome group and congenital heart disease, we had to compare with children, with healthy children. The congenital heart disease and the Down syndrome group had a birth rate less than the control group, and also significant. And the weight at the surgery were less for the congenital heart disease and Down syndrome group compared to the control group. This table talk about the characteristic and the clinical outcome for the surgical cohort. They, as we can see, the children in the Down syndrome and congenital heart disease group had a higher blood claim time, higher time for cardiopulmonary bypass, and they were using more vasoactive and inotrope, and also they had more heart block compared to the other group, the congenital heart disease only, and they were more susceptible to develop septicemia. And as you can see, chylothorax were only found in children with Down syndrome and congenital heart disease, and also the respiratory infection were found only in this group, congenital heart disease and Down syndrome. This figure talk about the result, the value of interleukin-2 and TNF-alpha. This is a comparison between the two groups, congenital heart disease and Down syndrome and children with congenital heart disease only. The black dots is considered as infant with Down syndrome, and the dark line, the children without Down syndrome. So the significant were only for the two groups, like the two parts, these two parts, it is the pre-op group, pre-op period, the post-op period, and here is the before the discharge. And as you can see, the infant with Down syndrome and congenital heart disease has a higher rate of interleukin and TNF alpha compared to the other group. And it was significant only for the pre-op and the post-op. And also for TNF alpha, it was the same, only significant on the pre and post-op. It's also the same. So these figure just talk about the other kind of cytokine. It's interleukin 6, 1 beta, and 8. And these reason like the rate for compare the children with Down syndrome and children without Down syndrome. If you see the children with Down syndrome as the children without Down syndrome has a higher rate of interleukin 6, interleukin 1b, 10, compared to children with Down syndrome. And the result was only significant for the interleukin 6, interleukin 1b. And these figure also are talking about the result for interleukin, and children with Down syndrome has higher rate of interleukin 1b, 1 beta compared to children without Down syndrome, but it was nearly the same for interleukin 1RA, and TNF beta also it was nearly the same result. But if you can see here, the erythropoietin and vascular endothelial growth factor were also evaluated, and the children with Down syndrome and congenital heart disease has higher rate of erythropoietin and also higher rate of GM-CSF, like compared to children without Down syndrome. So the discussion and comparing his study to other study in the literature, the author said that the study clearly demonstrates the difference in the inflammatory response between the two surgical group and in the perioperative period. And she said that it may provide an explanation for the significantly higher incidence of chylothorax and respiratory infection in infants with Down syndrome and congenital heart disease. In conclusion, she said that children with Down syndrome and congenital heart disease are significantly lower concentration of several cytokine compared to the control group and the congenital heart disease only. And erythropoietin and GM-CSF were significantly higher in the children with Down syndrome and congenital heart disease. So the assessment of the immune response may be suitable for predictable clinical outcome in these children. This study has many impacts, and it demonstrates that the children with Down syndrome and congenital heart disease have significant alteration of pro and anti-inflammatory immune response perioperatively. This change may contribute to adverse clinical outcome, including sepsis, chylothorax, and autoimmunity, and they may impact the pathogenesis and the outcome in post-operative and at a long term in the population of Down syndrome. And as we know that the children with Down syndrome has a significantly lower cytokine concentration and an increased erythropoietin. She think that this population can have if we like doing a panel or series of evaluation of cytokine in those children, we may prevent the complication in those children and come with some therapy, immunomodulation, and to limit the risk in postoperative in this patient. But as many studies, there was some limitation, like a smaller number of infants in the control group. And now we are going to review together the article and after to see what we can do in our practice. So if we take the author, the first author, we can say that the author in general, we can say that in the paper, the name were clearly mentioned and their credential also were mentioned. And yes, the first author already worked in the same field and as publication on publication on Down syndrome and heart disease. And about the journal, I think it's a great journal with it's an open access journal, easy accessible, and with an excellent impact factor. As we say, as we see before, it was an impact factor of 69.5. And about the title, in the topic, the title, the topic and focus of the study was clear, and it was meaningful and complete, and it includes the important variable, and the title were neither short or long, and it reflects the aim of the study. But the keywords of the study were not mentioned in the paper, but maybe on the proposal, we don't know. And about the abstract were well structured, informative and meaningful, and it was comprehensive. Clearly, it gives a gist of the whole study. And the introduction of the paper was concise, and it was built on existing literature and was logically present without after the research on the subject without omission of important study, and the citations were relevant and pertinent. And the methodology as appropriate study design, and the population were well described, and clinical data collection well described. For the result, she present the result in a logical and comprehensive way, and the data were properly titled, and all the table and figure are well explained, and the results are based on the aim of the study. For the discussion, it was meaningful, and the author highlight the important point, and compared to existing, it was compared to existing literature, and for the limitation, it was a relatively smaller number of infants in the control group. The conclusion was meaningful, and it was based on the discussion and on the result, and the research question has been answered. So yes, the article was funding, and for the references, it was acceptable with 43, but the references are from 1991 to 2020, and she used the Vancouver style to do the reference. Now we will discuss about the internal validity of the study, and on the Zoom you can react also, and in the meeting room you can react.
Let's check on Zoom if there is some.
If you have question on the Zoom, if you have to react, also to give your opinion about the subject and your experience about the subject, we are open to receive your comment.
I think that the first point is that if someone has some question,
Yeah. And this is the discussion in the article, right? You mentioned that interest rate in our study, cardiothoracic was exclusive in the Down syndrome group was adopted, which could be possible secondary to lymphatic malformation such as congenital lymphangiectasia. So the inflammatory status does not have anything or role in this cardiothoracic finding in this study.
Yes, it was, you say, page 4.
Yeah, page 4, paragraph 3. About the cardiothoracic, because they have like in their study, they have like almost all the patients, the cardiothoracic was 44% of the population of the Down syndrome, they have cardiothoracic. And they mentioned in their paper that's because the malformation, not because the pro-inflammatory steps Down syndrome.
Yes.
So
thank you. We have a question from another fellow, Dr. Hala. She asked, in the paper, the author first described that the Down syndrome population is more likely to develop in limb. You can comment. Yeah, so this population, it's like the chylothorax in this population is more likely due to malformation. And why the author give result, like if it was about the human response. Yeah, I asked myself the same question, and when I searched on the paper, she didn't mention anywhere that those children with Down syndrome have the chylothorax because of infection. She didn't mention it anywhere. But when you go to the literature, you see that because I think that she mentioned point likely, the children with Down syndrome, because of malformation as chylothorax, so they are exposed to drain, chest drain, and they will have a higher stay, hospital stay, and also more exposed to germ in the hospital. So they describe that maybe it's the reason why she told that she tried to put chylothorax in the context of humanity. It's because they are exposed to drain to long-term hospital stay, they could develop infection. Is there any other question?
Yes, the question is, do you check if there is some direct correlation between which type of interleukin or inflammatory protein and adverse or post-operative adverse events like chylothorax infection? It means if you have to suggest to one colleague that have the option to make monitoring preoperative, in your area, which one is the best indicator as preoperative? If there is, it doesn't make in multivariable analysis is different. Or what is your opinion?
Searching on the literature, I found that the interleukin-10 is a great can have a great reflect of the human system in perioperative. And also they make some study on rats to when they have less human response, they can give interleukin-10, but it's only on experimental. So maybe in the future we can try to.
There is a question, but not really.
What type of congenital birth disease has the Down syndrome? Okay, they only include children with Down syndrome, the children with Down syndrome and complete AVSD and VSD. The other were rejected. But for the non-Down syndrome group, they didn't mention what kind of disease.
Just a consideration, because it's an amazing paper, it's a small group, so I think we need to check again more and more. But generally, we know that the patient with the Down syndrome has fever, has infection, but I consider this patient like non-Down syndrome, so maybe I was wrong, because I just read in the paper there is an additional risk for reparative morbidity, also for ECMO patient. So maybe we were wrong. So it's not the same patient, Down syndrome and non-Down syndrome patient. So the question is how we can prevent, how we can, maybe we have to change antibiotics in Down syndrome baby, because we have a lot. We know the Down syndrome baby has fever, usually comfort of the non-Down syndrome, but we treat it the same way. We don't treat it differently.
Yes.
But it's amazing this paper because the mobility is different. Also for ECMO patient, I just read in the paper.
Yes, thank you for the question and excellent point. And it was the reason why I chose this paper. I wondering children with Down syndrome fever, yes, he has a less immune response.
It's normal. because
It's
it's
normal.
Down syndrome, very-
Yes, but as I think that I will go the same way as the author. Like if we know that those children are more likely to develop infection, or we should we should do the sampling like they did in the study. If we could have the cytokine panel for these children, like in Peru, we made a sample to see the profile, and on post-op to see if we had to manage with the treatment, like to give other medication to prevent from an infection. And I think it's important. It will be important to add.
There is another question, probably.
Probably. Yes, we were just talking about this point, like seeing our patient with Down syndrome, not consider them like normal patient, and we have to do more exam like to put cytokine panel in our list of exam to do for patient with Down syndrome in perioperative, and like that we can manage, prevent the complication.
Maybe we will consider going for bringing like interleukin injection, interleukin injection, and some antagonists for interleukin-6, or to be involved in the treatment of
This
patient.
question.
Yes. I wanna, my special thanks to the Congenital Earth Academy again, and to my colleague fellow, and also to my hospital from Haiti, here with us, and special thanks to you, Dr. Alido.
Just for that.